So, hi guys, welcome to the Med Crash Course series. We're doing the finals crash course today, going through medicine-based SBAs. We've got Dr. Sally Barker, Dr. Dalia Abdulrahman, Dr. Andrew Hu, and myself, Amash, and we've all put together some SBAs. And just a shout out to our contributors who also wrote some SBAs for us. Got Dr. Kalpana Jayasingham, Dr. Anaya Scott, and Dr. Nitish Sharma, who kindly written some stuff, and we've created an SBA bank from everything we've done. So how the session is going to work is we'll go through 50 SBAs in the session. We'll give you about 30 seconds to have a look at the answers and put your answers in the chat, and then we'll go through an explanation of why that's the right answer. So if everyone's happy, we can start. I think Sally's going first.
Cool. Yeah. Hi everyone. Thanks so much for joining. My name's Sally. I work at Ealing along with Ach and Andrew, and I'm going to be covering, if this works, Gastro, ID, and Power Care. So the way that I'll go do things is that there's 3 questions for each of these, plus an extra bonus question. So we've got 10 in total. Because we don't want to make the session too crazy long and overrun, I'm going to move quite quickly through the different questions. If you have questions about the questions, we can go through them at the end. Don't worry, there's loads of information on the slides. You will get the slides with the information on it, and there's going to be a whole other SBA question bank coming out too. So if you feel like you've missed something, it's probably on one of the slides somewhere, but we can talk about it at the end if we've got time. So yeah, to start off, gastro. So first question for gastro. A 29-year-old female presents to the GP with an irritated red rash at both corners of her mouth. She thinks it's likely to be a manifestation of her childhood eczema exacerbated by wearing a face mask, and she's asking for a steroid cream to help clear it up. On further questioning, she also describes feeling more tired than usual over the last month, and she thinks she's lost a little bit of weight. So she's not noticed any blood in the stool, but she's noticed that the stools have become lighter in colour and can float in the bowl. She's also noticed that she's been bruising more easily. On examination, she has several small bruises on both chins, as well as a rash at the corners of her mouth, but actually on examination, the abdomen, it's normal, soft, non-tender. Are also normal, and a stool sample is negative for blood, but shows high fecal calprotectin. What is the most likely diagnosis? You've got your 5 options there. So I'm going to give you guys about 20 to 30 seconds. If you want to put your top differential in the chat, and then we'll go through the answer. Okay, amazing. I'm going to get some answers through, mainly B's. I've got a 1A. Anyone else brave enough to disagree with B before we go through? No? Cool. Okay. So yeah, the correct answer is B. So this is a presentation of celiac disease. I included this question and I kind of wrote it in the way that I did, just because I think what's really difficult in SBAs, especially towards the end of med school, is actually recognizing what is being described by words, what the signs that you might only have seen in pictures or in patients themselves. It's maybe a little bit of overlap with derm here, but essentially this irritated red rash at the corners of the mouth isn't typical of eczema at all. And what we're describing here is actually angular chelosis. Oh, I've got someone in chat saying they can't see the slides. Is that true for everybody?
I can see them.
Okay, cool.
If you can't see the slides, maybe just leave the meeting and then come back in.
Yeah, so this is actually a description of angular chelosis, and angular chelosis can be caused by lots of different things, but essentially it shows an iron or a B12 deficiency. if you've got an iron and B12 deficiency, you've got some kind of small bowel pathology if we're thinking about a gastro cause. So the only small bowel pathology out of these 5 options is celiac disease. Celiac disease is a tricky one because actually the classic presentation of sort of change in bowel habit in response to gluten isn't actually what people will come to the GP complaining of. So again, you can kind of lose that differential in quite a complex case history from a patient. Here we've got a slide just going through like the basics of celiac disease. At final year, this should all be common knowledge, but just remember that it only can be definitively diagnosed on biopsy. And your like 3 buzzwords that you're looking for in pathology questions are total villus atrophy, intraepithelial lymphocytes, and crypt hyperplasia. And the other thing to just point out with this question is something that I didn't know in final year and found out through like doing some past med stuff, was that high fecal calprotectin was something that I had only really associated with IBD, which is why I understand why people have put ulcerative colitis as one of their answers. Actually, you can get high fecal calprotectin in uncontrolled celiac disease as well. So IBD and celiac disease can both show high fecal calprotectin. So yeah, just beware of those traps of associating sort of signs, symptoms and test results with like a single differential only. So yeah, summary of this question, celiac disease has a really diverse presentation. Watch out for it, always keep it high on your list of differentials for GP presentations with sort of vague systemic symptoms. Look out signs of vitamin deficiency, but more than that, try and trace back the vitamin deficiency to the top part of the sort of gastrointestinal system that absorbed, and that will give you the clue to the answer. Great. Question number 2. A 45-year-old female patient presents to her GP with difficulty swallowing. She can't specify when it started, but she now feels unable to swallow most tough food, such as meats and raw vegetables, saying that they just get stuck in her throat. She's still able to drink water, but has also found that she coughs and splutters if she drinks it too quickly. She initially thought that this was due to her recent COVID infection that left her with a perpetually sore throat. She has not experienced any vomiting apart from the occasional regurgitation of food, and her bowel habits are unchanged. She doesn't think she's lost any weight, and her examination and initial bloods are unremarkable. Her past medical history includes GORD and generalised anxiety disorder. The GP orders an Oh, sorry. Sorry. The GP orders an OGD, which shows saliva retention, and a barring swallow, which shows a bird's beak esophagus. What is the most appropriate first step in management? So again, you guys got 30 seconds, and pop your answers in the chat, and then we'll go through it. Okay, so I'm seeing a lot of B's and D's as people's top answers. Actually, the initial most appropriate first step in management is medical, and that would be your calcium channel blockers. So I'd hope that at this point, like everyone can recognise that what this lady is suffering from is known as achalasia. The kind of real buzzword for this is that bird beak esophagus. There are lots of different differentials for difficulty swallowing. If that's something you guys want to revise, I cannot recommend more the Oxford Clinical Cases flowchart, which talks about sort of like motor causes versus sort of functional causes of difficulty swallowing. In terms of achalasia, as you'll see, we've got another beautiful slide that goes through loads of different detail about it, but it's a loss of the ganglion cells in the myenteric plexus. So what you get is a sort of failure of peristalsis, as well as this sort of blockage at the bottom from the lower esophageal sphincter failing to relax. This means that you get a complete change in the pressures in the esophagus. Hypothyroid, cannot get fluid down. Oh. So yeah, so that's what achalasia is. And again, in terms of presentation, you're thinking a middle-aged sort of epidemiology, and it will be a slow process. Again, where by the time people present, it actually might be fairly advanced and require quite like reading out to find the initial starting point, as well as how it progressed. In terms of investigations, as we said, like what you'll see on PassMed and on sort of SBAs is this like bird beak thing on barium swallow. But just remember, if you do get a question about the investigations of achalasia, then an ODD should always be first line, especially in a middle-aged population who are having difficulty swallowing, because malignancy is something you definitely don't want to miss. So that would be sort of an esophageal malignancy, you know, progressing from a Barrett's esophagus, that kind of thing. The reason I wrote a question specifically on achalasia was actually because it came up in my images station in my paces. So we had an image of a barium swallow with the bird's beak, but actually what they questioned us a lot on, because I think, you know, the majority of us could recognise that was achalasia, what they actually questioned us a lot on was the management, hence why I've designed this question. Whenever you're in paces, as I'm sure you guys know, it's always best to talk about conservative, medical and surgical management, often in that order, because often that's seen as more and more invasive, and therefore you should always start with conservative, followed by medical if there is an option, followed by surgical. And the right answer is here in that, according to BMJ best practice, before surgical intervention is considered, you should at least try nitrates or calcium channel blockers first line. And the purpose of them is actually to just muscle relax and that lower esophageal sphincter, and therefore balance out the pressures and allow the patient to actually, you know, get some food, get some fluids down, and see if that relieves their symptoms enough in the sort of medium to long term. If we're talking about surgical intervention only, actually laparoscopic cardiomyotomy, so that would be C, has a much higher success rate than pneumatic dilation of the esophagus, which is now considered slightly more old-fashioned. And then at your absolute last line is botulinum toxin, which again would, you know, cause paralysis of that lower esophageal sphincter, which could, like, you know, predispose to quite severe GORD as a result, and that, you know, Barrett's esophagus along the line. So yeah, correct answer here is the most appropriate first step in management for this lady is actually a calcium channel blocker. There might be some counselling about possible surgical interventions further down the line if calcium channel blockers cease to work, and botulinum toxin would be sort of your last resort. Okay, so, oh yeah, little picture of a cardiomyotomy just to kind of give you sort of an idea of it. What I thought was quite interesting is that they actually use the stomach itself and draw up higher, and that also helps to prevent the GORD, which can result from after one of these procedures. Okay, so this is the last question on gastro, and we're now revisiting peds, just to give everyone a bit of pediatric flashbacks. So a 1-month baby boy called Adam brought to the GP practice by his concerned parents. They report that the baby has been vomiting after feeds for the last 2 weeks. It started intermittently, but has been after every feed for the last few days, totaling 8 episodes in total yesterday. They described the vomit as projectile and milk-like in colour, smell and consistency. Adam is exclusively formula fed due to latching issues postnatally. There were no complications during pregnancy or birth, and he is the parent's first child. The GP assesses Adam and organises an ambulance to transport Adam and his parents to hospital for urgent fluids resuscitation. An urgent upper GI study shows the string sign. What is most likely diagnosis? Yeah, you guys have already got this. C, excellent. Seems like we're super happy with pediatrics. Yeah, I think the thing here is just to know sort of key facts about each differential. I said achalasia, you're thinking more middle-aged. It's very, very rare to see it in pediatrics. Volvulus, they present with symptoms of bowel obstruction. So yes, you would get the vomiting. They'd also be totally constipated and have a distended abdomen. Hirschsprung's disease is a disease in which you lack the sort of the plexus of the colon, and therefore you end up with a patient with a pediatric patient who either never passes meconium or passes it very late or suffers from chronic constipation. So again, a very different presentation to the one described here. Intussusception, again, can cause vomiting, but your kind of buzzword there is your red currant jelly stool. Correct answer here is pyloric stenosis, hypertrophy of the pyloric sphincter muscle. It means that this projectile vomiting, it sort of starts off as normal vomiting, gets more and more projectiles, there's more and more hypertrophy of the pyloric sphincter. Your peak is at 4 weeks, and for some reason it's more common in formula-fed children, although we're not quite sure as to why yet. Okay, great, we've all survived gastro. Moving on now, we've got just a few questions on infectious diseases. So this question 4, 36-year-old male patient presents to A&E with a 3-day history of fever, chills and vomiting. On examination, he is visibly sweating and pale. Examination of the hand shows non-tender, reddened, irregular macules bilaterally on the palms. Skin tug is reduced, but cap refill is less than 2 seconds and the pulse is regular. Auscultation of the chest reveals a soft ejection systolic murmur. Lung sounds are clear and percussion is resonant throughout all lung fields. Abdomen is soft, non-tender, and limbs are pain-free with no evidence of rash. His observations are as follows. He's got a respiratory of 19, oxygen sats of 98 on room air, heart rate 98, blood pressure 123/82, and temperature of 38.5. No past medical history, no regular medications. Urine dipstick is clear. Routine bloods are taken, including blood cultures, but we don't have those back yet. Working slightly more in real time for this question. We request a chest x-ray, but we do manage to get a bedside echo, which shows evidence of small vegetation on the aortic valve. At this point, the information that we have, what additional features on examination would confirm the diagnosis of infective endocarditis? Yeah, you guys all absolutely smashed it. The answer is D. Congratulations. So just to explain what's going on here, so in terms of diagnosing infective endocarditis, we're looking at the Duke's criteria. There's loads of mnemonics out there on the internet. The one I used for my finals was B5er. Essentially, in order to definitively diagnose infective endocarditis, you are supposed to have either 2 major criteria, 1 major and 3 minor, or 5 minor criteria in order to say that this is definitely infective endocarditis. Looking at our gentleman that we've just described here, he has got one of the major ones in that he's got this echo evidence of vegetation. He might have, a typical bacterial blood culture, but we don't know that yet. Looking at the minor criteria, we know that he's got fever, and we know that he's got what I very laboriously described as non-tender, reddened, irregular macules bilaterally on the palm. So these are Janeway lesions. Again, just wanted to reiterate, it's really important to be able to correspond signs and symptoms with a very long description in an SBA rather than a picture or rather than a memory. It's annoying, but it's just what we have to do for exams. So this is a classic description of a Janeway lesion. They're non-tender. It's a reddened palm-like lesion, whereas Osler's nodes are small, they are tender, and they tend to be on the sides of the fingers, and they don't tend to be erythematous. In terms of how we categorise them, so Janeway lesions is actually a vascular phenomena, and that's why it's not painful. Other vascular phenomena would be something like an intracranial hemorrhage, whereas what we're looking for in the Osler's nodes is what we know as an immunological phenomena, and that's why it is tender. So it's about recognising classic signs and symptoms of infective endocarditis, but also being able to recognise them as descriptive terms and then being able to categorise them in order to fit into your modified Duke's criteria to make that diagnosis of infective endocarditis at the bedside. But you guys all got it right, so we'll move on. Question 5, still infectious diseases. Should be quite a simple question. 25-year-old female presents to a GP, intermittent burning sensation when passing urine. No changes to urinary frequency, no changes to colour, no changes to smell of the urine. Her urine dipstick is positive for nitrates only, and she's negative on a pregnancy test. Abdominal examination is not significant, and she is systemically well. She has no past medical history. She takes a contraceptive pill. She's never had a UTI before, but she was talking to a friend at work about her symptoms, and her friend told her to go and see the GP. What is the most appropriate management plan for this patient? I'm going to give you 30 seconds to pop your answers in the chat when you are confident. Okay, I'm seeing loads and loads of the answer A. I'm so sorry, everybody. The answer is not A, actually. It is, oh, can't get the slide to move on. Let's try now. E. So I wrote this question probably quite sneakily, but I just wanted to highlight from my own experience that there are certain really common conditions that's really worth being up to date on the guidelines for your exams. I don't know if your exams are open book and you might be able to have these guidelines to hand, but things like hypertension, diabetes, UTIs, like really classic GP stuff, just make sure you're absolutely sure what the latest guidelines say. So again, according to BMJ best practice, because this patient only has one mild symptom, despite the fact that she has nitrates positive on her urine dipstick, it doesn't warrant empirical antibiotics. It only warrants a backup prescription if the symptoms don't resolve by themselves within 3 days. If she has more than one mild symptom, or if her symptoms are causing, if her one symptom is causing a significant impact on her daily life, then you could consider a 3-day course of nitrofurantoin or trimethoprim. Just made a note here, always remember in pregnancy, to screen for pregnancy, especially when giving trimethoprim because it's a folate antagonist. In terms of everyone putting A, I think, to be honest, in real life, a GP would still be very justified in giving a 3-day course of nitro. So I guess here I'm kind of just making a point about guidelines being quite changeable and trying to be as up to date as you can with the really common stuff for your exams. I think in real life. Sorry, I'm seeing a few questions. So in terms of nitro or trimethoprim, they're both listed as appropriate first line options. I think deciding between them would depend on local guidelines, which again, if you're in PACES and kind of giving this as like a verbal report or a verbal presentation, I think you would just say you'd refer to local guidelines regarding the most appropriate option. I saw there was a second question, but I can't see it now. I'll have a look at the end. I realise it's probably quite a controversial question, but I thought it was worth putting in just for some consideration. So yeah, if you've got any further questions, pop them in the chat and we can have a look at them at the end. But for time's sake, let's just move on. Okay, so this is question 6. So we're still on infectious diseases. Quite a quick one. So out of the following options, what is the correct initial management for HIV? I will give you 30 seconds to pop your answers in the chat. Yeah, I'm seeing loads of right answers, exactly. So the most appropriate option out of the ones listed is A. And that's because in terms of HIV management, obviously you're thinking about your antiretroviral therapy. There's loads of different targets. I'm sure you guys all know that big diagram that kind of shows how HIV enters the CD4 cells and replicates, but essentially you need 2 different either nucleoside or nucleotide reverse transcriptase inhibitors. Remember that HIV is a retrovirus, plus one other agent, the most popular ones at the moment being protease or integrase inhibitors. I chucked in a few red herrings here. So Cetrin is something you will see that patients with HIV are often taking, but that's actually for PCP prophylaxis rather than treating the HIV itself. And I've also, popped in the TB treatment just for fun. So yeah, just sort of a baseline fact to know about HIV management. Oh, you really won't need to know the names that I've mentioned here of the most common agents used at the moment. Just pop that in for FY1 knowledge. My first placement was infectious diseases, so it was quite useful to know a few of the local brand names circulating at the time. Okay, question 7. So this is our pediatrics infectious diseases question. Also a little bit of gram stain knowledge to refresh. So 10-day-old infant, Richard Skaboo, fevers, irritability and dehydration. We suspect meningitis. He has an LP. CSF shows gram-positive rods. What is the causative organism? Pop your answers in the chat. Yeah, great. Someone's already popped in C. That is correct answer. So I think in terms of infectious diseases as a topic, in terms of exams, meningitis will definitely come up. It's common. It's got a high mortality rate if not recognised. So obvious candidate to be tested on. I think in terms of causative organisms, just trying to remember maybe the top 3 for adults and the top 3 for paediatrics, just so you can differentiate. So your top 3 for paediatrics are E. coli, group B strep and listeria. And then it's about knowing your gram-positive and gram-negative staining and kind of working out how you're going to remember how different ones fit in. In terms of gram-positive rods, I just used to remember A, B, C, D, L, which isn't very creative, but yeah, it was just like, that's actinomyositis, that's Bacillus cereus, then you've got your Clostridium, diphtheria, and listeria. And it just meant that, yeah, you could kind of reel it off and look on the list and, oh, look, there's listeria. You don't actually need to know anything about pediatrics at all. So yeah, I would just say they're the two things to know your grand stain flow charts, and kind of have an idea of what's like top in terms of the epidemiology. Cool. Okay, guys, so we're now on to palliative care. Thank you for sticking with me. Palliative care, so these questions actually may be more commonly found in something like the PSA, which I know some of you would have already taken, but still really, really important topic, and also kind of prescribing things that you will have to do very early on in FY1 without anyone really checking that you're comfortable with it. So worth kind of keeping at the top of your mind. So this question 8, 55-year-old patient presents to A&E with severe nausea and vomiting. She has stage 3 cervical cancer, undergoing chemotherapy and radiotherapy. Her latest round of chemotherapy, cisplatin, finished 3 days prior to presentation. Still able to tolerate fluid. She has severe nausea, a dry mouth, and yeah. So I can see a lot of people have put A. I think, again, between A and B, it's a close call. We know that this patient is already suffering from a dry mouth, and we know that the most likely, by a long way, trigger for her nausea and vomiting is the chemotherapy. This means that it's inappropriate to use cyclizine, which dries out your mouth more and is more for a sort of vertigo-induced nausea and vomiting. Definitely inappropriate to use hyoscine bromide, which is a sort of prevents respiratory secretions and isn't commonly used as a nausea and vomiting antiemetic at all. Chlorperazine is actually an antipsychotic, and it can be used in refractory cases of nausea and vomiting, but definitely wouldn't be kind of considered as most appropriate first line here. Between ondansetron and metoclopramide, so yeah, they have different uses. Current guidelines, it's actually in terms of acute onset versus delayed onset biochemical nausea and vomiting, such as that caused by chemotherapy. There's more evidence towards metoclopramide in a delayed presentation, so more than 24 hours after the last dose of chemo. We don't have enough time to go through this sufficiently now, but as you'll see in a moment, I have got a slide that talks about all the different receptors and kind of gives a bit more context for that answer. But I think as long as you can kind of rule out CDE and justify that in your minds, and then the rule here is that for acute onset nausea and vomiting post-chemo, you would use ondansetron, and delayed presentations, you're looking more for metoclopramide, just looking at the evidence base. Okay, question 9. So this is your sort of classic opioid prescribing question. Patient with extensive metastatic breast cancer is admitted hospital with decreased consciousness, severe respiratory compromise, and acute kidney failure. Consultant reviews patient. After discussion with her oncologist, the palliative care team, and family members decide the patient is for end-of-life care only, and any active management should be stopped. The consultant asks you to convert her current analgesia to syringe driver as the patient is prepared for transfer to the local hospice. Her current medications is oral morphine sulfate, modified release 40 mg BD, oral morph 10 mg PRN, max 2 hourly, and cyclizine 50 mg PRN by IM injection. So you notice that she has required 4 doses of the oral morph and 0 doses of cyclizine in the last 24 hours. What is the most appropriate prescription for the syringe driver? So yeah, I'll give you 30 seconds for this one. It requires a little bit of maths. Pop your answers in the chat when you're ready. Cool, yeah, so I can see we've got a correct answer of A in the chat already. That's really good. So yeah, just to explain the rationale for that, and also just FYI, oral morph is morphine sulfate immediate release, so I could have easily written that instead. I just used a brand name because actually, at least where I work, where it's paper drug charts, people tend to write either their brand name or the generic, so it's worth recognising both. So sort of your standard rules for converting oral to subcut in terms of opioids is to divide by 2. looking at how much we should actually prescribe in the first place. So we want to calculate how much she's using over a 24-hour period. We know that she's having 40 milligrams BD of modified release, so that's 80 milligrams over 24 hours. And we know that she's needed 4 doses of the immediate release. That takes us up to 120 milligrams over 24 hours. If we divide that by 2, that gives us 60 milligrams as our sort of regular dosing. So that whittles our answers down to either A or E. And then looking at how much we should then give as a PRN, the sort of common rule of thumb is to include 1/6 of your total 24-hour dose. So if we're giving 60 milligrams over 24 hours, 1/10 with 10 milligrams. And then lastly, in terms of the cyclizine, so again, it's just common practice that for all of your anticipatory meds, they may not have needed it in the last 24 hours, but if they're for end-of-life care, that definitely doesn't mean they won't need it in the next 24 hours. So keeping PRN anticipatory meds is best practice. So I would include the cyclizine, which doesn't need to be converted, doesn't need to be numerically converted between subcut and IM. So the correct answer there is A. Lovely. Okay, so then I think we've just got, this is the last question from me. Again, quite a quick one. F1 on call overnight, receive a bleep about a patient on an end-of-life care pathway. Family at the bedside and I'm concerned about her breathing. You assess patient, notice thick spluttering noises on inspiration. What is the most appropriate pharmacological management? Yeah, so I can see we've already got some answers coming through. Exactly. So hyoscine or glycopyrronium. Oh, I apologise, got a little spelling mistake there. Are most commonly used to reduce respiratory secretions at the end of life. Your other option as well is to use suction at the bedside. But yeah, these are sort of classic anticipatory meds that you'll see written up for other reasons. Midazolam for terminal agitation, haloperidol is another antiemetic, and then of course we've talked about opioid analgesics. So yeah, all of these are kind of options for different symptom management for patients on end-of-life care pathways. So that's it from me. Actually, do you want me to answer any questions now, or do you want to move on to the next person?
If there's any more questions, just ask Sally right now, and then we can move on to the next person. So we'll give about 20 seconds to see if anyone puts anything in the chat, and then we can move on.
Cool. Let me see if I can see the chat. See if there's any questions I missed. Oh yeah, so there's one question left about the UTI from Gavin, saying that if she'd had these symptoms for a few days, could you then give antibiotics? So again, actually BMJ best practice doesn't give guidance about the duration of symptoms, it only gives guidance about the number and the severity. So I think that would be a bit of a judgment call. As I say, I think I was probably quite a bit mean with that question. But yeah, as I say, BMJ best practice says if it's just one symptom, not causing too much bother, then you can just send the patient home with a backup prescription to use as they want to, alleviate our loads of antibiotic resistance that we've generated for the last 10 years or so. But yeah, any other questions?
Yeah, so I can read them out to you. So next one is, would Crohn's be appropriate answer for the first question?
Would Crohn's be? Yes, it would be, because Crohn's can affect small bowel, unlike ulcerative colitis. So yeah, if Crohn's was one of the answers, then yeah, I would say that it would be very hard to differentiate between celiac disease and Crohn's. I'd probably say celiac disease is maybe slightly more common, considering that she'd had quite minimal changes in bowel habit, just sort of more of loose, greasy stool, as opposed to any blood in the stool, any significant abdominal pain. But it would be a valid differential for sure. Why was it not cyclizine for the first antiemetic question? Yeah, so no, good question. When you look at slides, we can go back and have a flick actually. It just kind of depends on the receptors that are affected. So yeah, for this patient, the most obvious trigger being the chemotherapy. So we're looking at the serotonin and the dopamine receptors in the chemoreceptor trigger zone. Cyclizine, it does affect, it affects mainly antihistamine and anticholinergic receptors. So yeah, just kind of like where it affects in the brain and different receptors that it affects. Chemotherapy is induced nausea is sort of best alleviated by the ondansetron or metoclopramide, whereas cyclizine you might see more commonly used in something like BPPV or labyrinthitis.
Dahlia, I'm a respireg at West Middlesex Hospital. Have my slides come up?
Yeah, they're coming up. Yep, they're up.
Loading. Okay, perfect. Right, so today I'm going to be going through respiratory, cardiology, oncology and rheumatology with a few in-betweens that are more vascular questions and also some peds questions. Righty, let's get to the good stuff. So, first question. A 64-year-old man presents with problems with his chest for the past 10 years. On examination, he has a barrel-shaped chest. There's evidence of use of the accessory muscles of respiration and pursed lip breathing. Which one of the following routine blood tests is most likely to be found in this patient? So if I give you 20 seconds to just pop an answer in the chat. Which of those are you expecting to see?
Do you need me to read the chat out for you?
I can see them.
Okay, cool.
Perfect. So it looks like everyone's gone for D, polycythemia. So yes, this I'm describing the classic COPD patient, and polycythemia is this response that you get to chronic hypoxemia, which triggers an increased production of erythropoietin by the kidneys, and so you get a secondary polycythemia. And now this is also the case in other respiratory diseases where gas transfer is reduced, such as obstructive sleep apnea and hyperventilation syndrome. Right. Next question. Which of the following flow volume loops would represent a normal appearance? Again, another 20 seconds. Which one is normal? Excellent. I'm pleased to see that everyone's putting in A there. So if you look at these flow volume loops, I think the typical representation of one is A. But just as a quick reminder, x-axis represents time, y-axis changes in atmospheric pressure. So the negative deflection is the inspiratory flow and the positive deflection is the expiratory flow. And from that, B is your typical emphysema. So you've got that early airway collapse on breathing out, and the inspiratory part is normal. C, you've got a fixed upper airway obstruction. As you can see, the inspiratory part is flattened. D, you've got variable upper airways obstruction because actually you're managing to expire a bit more, so the expiration looks almost normal. And E is your typical restrictive pattern where the volume is reduced. Next question. You'll review a 76-year-old man who has the following clinical signs. So unilateral reduced chest expansion, reduced breath sounds on that side, reduced percussion note. Which one of the following clinical conditions would provide these signs? I'll give you a bit longer on this one to have a think about it. I'm getting some D's, some E's. Okay, so about half of you are right there. The correct answer is E. And so the reason being is with pleural effusion, the buzzword is stony dull to percuss. Yes, you would probably get, if it's a significant effusion, reduced chest expansion. You would get reduced breath sounds, but the percussion note is typically stony dull. As to how you can differentiate on auscultation, I guess when you hear enough of them, but I'm not actually sure that I can quite appreciate the stoniness of it. In terms of, but that's basically the only difference between D and E. For consolidation, you'd probably get reduced chest expansion, but breath sound would probably be bronchial. You might hear some creps. For fibrosis, you wouldn't have any change in the percussion note or the breath sounds, but you typically get that fine inspiratory crepitation, a bit like Velcro on auscultation. And otherwise you just get the reduced chest expansion. With fibrosis, it could be bilateral, and that's more often than a unilateral fibrosis. So that would cause a bilateral reduced chest expansion. And then to go over pneumothorax, you typically get an increased percussion note, so it'd be hyperresonant because there's air underneath. Righty. Next question. The following are all true with regards to chest drain insertion in children, except, so which one is false? So a chest x-ray should be performed after insersion. B, in the neonate, the treatment of a tension pneumothorax involves insertion of a cannula in the fourth intercostal space, mid-clavicular line. C, the procedure requires a full aseptic technique. D, local anaesthetic should be infiltrated with an orange needle. E, full monitoring of oxygen saturation and pulse rate is required. Have a think, a little bit more difficult. Someone's put in B. Okay, so I think what's partly difficult in this question, it is vague, and some questions are really vague. Unfortunately, we can't avoid these in the exam. E, of course, but it kind of, it makes you question, well, what does full monitoring mean? But obviously we'd need to monitor these. They don't need to necessarily be connected to a pulse oximeter the whole way through, but at least pre and post observations following the chest drain. In terms of D, I mean, you're going to be using an orange needle anyway, but you know, obviously you also use other sizes of needles, and that's kind of neither here nor there. The answer is in fact B. That's correct, and that's because you don't change intercostal space because they're children. In fact, it's even more important you go in the which intercostal space, guys. Pop it on the chat. I think fourth intercostal space, you probably hit heart if you're on the left. No, second. Yeah, that's it. Second intercostal space, because typically with a pneumothorax, it's air, it'll float, so it's fine to go near the apices, and you're less likely to hit anything else. All right, and that's on there on the PowerPoint. Next question. 8-month-old girl is brought into ED on examination. You know, evidence of bilateral crepitations in her chest with associated recession and cyanosis. What is the likely diagnosis? So she's 8 months old. This is a PEDS question. Just have a think about what's common in this age group. Great, I'm getting some answers already. Excellent, yes. Bronchiolitis. This is most common in those below the age of 1, and you treat with oxygen and bronchodilators. And do you know what's the most common, as an aside, what the most common organism to cause bronchiolitis in infants is? Someone pops it on the chat. Yes, excellent, RSV. Brilliant. Next question. Which of the following statements about abdominal aortic aneurysms is incorrect? So A, it's more common in males than females. B, 10% have an associated popliteal aneurysm. C, a diameter more than 4 centimetres requires operative intervention. D, renal failure is a known post-operative complication of AAA repair. E, 5% risk of rupture when aneurysm reaches 6 centimetres diameter. Getting a lot of C's there. Yep. You're right there. So popped in the nice guidelines there. In terms of monitoring, you just have to learn these, I'm afraid. When the diameter is more than 5, well, actually on there it says, so every 3 months if it's 4.5 to 5.4, and every 2 years if 3 to 4.4, and that's just monitoring. So repair is only if they're actually symptomatic, or if it's greater than 5.5, and whether they're symptomatic or not, they should be being teed up for repair. And I mean, the bottom one there is just signifying a rapid growth. So if it's growing by more than 1 centimetre a year and you're getting to 4 centimetres, you can also think about that. Right, next question. A 38-year-old man attends ED complaining of 12 hours of intermittent chest pain. His pain is central in location with no radiation but some associated nausea. He has a family history of cardiovascular disease. His TROP-I is 0.05 and his ECG shows no ischemic changes. He asks you what will happen next. What should you tell him? Does he need to be admitted? He requires an ETT before he's discharged. An echo would be useful in his further management. He can be safely discharged without further follow-up, and he should be started on aspirin. What are you thinking? Just waiting for a few more answers. Okay, so we seem to be between A and C. Now, the reason I included this question is it happens quite frequently, and people people understandably tend to be more cautious when it comes to suspecting ACS. Okay, but the key here is we're looking at the timing. And this gentleman has had 12 hours of the intermittent chest pain. So the troponin is actually the 12-hour troponin. So if the 12-hour troponin is negative, essentially, he's fine to go. He's also nauseous, and that's suggestive that it's probably a GI cause. Okay. If you caught him sooner, You could do an initial trop on admission and then repeat. So this will vary depending on the trust you're at, but with the high sensitivity trops, you repeat at 3 hours. And if that shows more than a 50% double up, then you've got your answer and they should be admitted, and it's probably an ACS. Whereas if it's negative at 12 hours, no, he's fine to go home. Quite often, you know, some of these patients are referred to the medical team to be admitted when it's not necessary. So the answer there was D. Sorry, so just going back to the last question, someone's written that they thought bronchodilators aren't indicated in bronchiolitis. Correct. So it is supportive treatment with oxygen, and you can use bronchodilators in the short term. It's not something we start as a management, as a regular thing, but if we wanted to in the short term, we can use them. All right, going on to the next question. I don't know if that's skipped. Hang on just a sec. Have I skipped? Okay, I'm on question 18. 84-year-old woman represents to ED 2 weeks after admission for control of an irregular heartbeat when she was started on digoxin. She now complains of dizziness and intermittent shortness of breath. Her drug history includes atenolol 100 milligrams once daily. Her ECG today shows a rate of approximately 40 beats per minute with no association between P waves and QRS complexes. What is the next step in her management? Give you 20 seconds. So she's got an irregular heartbeat and recently started on digoxin. She's feeling symptomatic. Waiting on a few more answers. No. So now if I give you a clue, the question is, what is the next step in her management? That's a clue. Okay, great. So yes, the answer is E. Okay. Now most of you got the right idea. So some have put D for stop digoxin, but it is important to just check the levels in case there is any potential toxicity, which would account for a bradycardia. Now, someone has also asked whether they ought to have a temporary pacing wire if they weren't on digoxin. Very good question. Her heart rate's actually being maintained at 40. So, I mean, if she was particularly symptomatic and had a second, third degree heart block, obviously with, you know, hemodynamic compromise, that would be our next step. But in the first instance, and now this is important with any question you get, it's important to have a read of what the actual question is. And here it's what is the next step in her management, and we would of course take bloods as a next step. Alrighty, the next question. The following are all true with regards to Fallot's tetralogy, except commonly associated with left ventricular hypertrophy, associated with cyanosis, surgery is the treatment of choice. It's commonly associated with right ventricular hypertrophy, or it's associated with pulmonary stenosis. Sorry, I missed out the A there. Just a recap on Fallow's tetralogy. Okay, great. So most of you are correct. So here's a heart with Fallow's, and you can see the features: overriding aorta. You've got the pulmonic stenosis that eventually leads to pulmonary hypertension. You've got the ventricular septal defect and the right ventricular hypertrophy because of the increased pressures in the right heart system. So yes, the correct answer was A. And someone's popped a question there, D and E are linked, right? Well, yes, so you've got that right ventricular hypertrophy as a result of the, well, to be fair, the pulmonary stenosis is more because of the overriding aorta than the right ventricular hypertrophy. That right ventricular hypertrophy causes an increased pressure, which then leads to pulmonary hypertension. Okay, next question. A 52-year-old man presents to the hospital having had 10 bouts of diarrhea since the morning and severe abdominal pain. He states that he has severe facial flushes intermittently. On examination, he is slightly anxious and breathless while lying flat. There is a peripheral pitting edema of the ankles, and abdominal examination reveals 3 centimeters bulky hepatomegaly. Cardiac sounds are abnormal, with a pansystolic murmur and a raised JVP. Which one of the following investigations is most likely to provide a diagnosis? Give you 30 seconds. So have a think. What is the likely diagnosis here? And therefore, which investigation will reveal that diagnosis? Any more for any more? Has anyone got the diagnosis? If that's easier. Excellent. Yes, so I think most of us at least know that this is carcinoid. Okay, and those who've answered have answered correctly. C. So this is the test for metabolites. So basically, metabolites of serotonin. Please, can someone mute? Okay. Sorry about that. Now, next question. So, well, no, we haven't gone over this. Sorry, that distracted me completely. Right, so facial flushing, watery diarrhea, abdominal pain, cardiac abnormalities, points towards carcinoid. This gentleman's got a carcinoid tumour, and we're basically testing for the metabolites of serotonin, which is what's causing these cardiac symptoms and also causes the watery diarrhea. Someone's asking what song was that, if Weiler would like to respond on the chat. Right, okay. Next question. A 5-year-old boy, no, wrong question. 68-year-old woman with a history of cancer presents to the hospital with abdominal pain and distension. On examination, she has a tender distended abdomen with 4 centimeters, smooth hepatomegaly and evidence of fluid shift. The abdominal veins are dilated and there is evidence of caput medusae at the umbilicus. Which one of the following diagnoses is the most likely in this case? Right on it, some of you. Excellent. The answer is E, Budd-Chiari syndrome, and this is because of obstruction of the hepatic vein, which causes this back pressure, which basically leads to a hepatomegaly. Typically, you could also get kind of a pulsatile one, although pulsatile, when it's described as pulsatile, it's usually in association with tricuspid regurgitation, and then you'd also get the dilated abdominal veins. Right. A 5-year-old boy is diagnosed with leukemia and subsequently commenced on treatment. The haematologist is in charge of his care is concerned about the possibility of acute tumor lysis syndrome. The following are all features of acute tumor lysis syndrome except, so is it hypokalemia, hyperuricemia, hyperphosphatemia, hypercalcemia, or an elevated serum urea? Excellent, some of you are on the money there. Tumor lysis syndrome is actually a result of hyperkalemia, okay? And popped a schematic there, which essentially cells, potassium is a intracellular electrolyte mostly. So if you get tumor lysis, the cells are being open. So if you ever think of lysis, potassium is actually coming out, so you'd get hyperkalemia. That's the best way to remember that one. Okay, 43-year-old man presents to his GP with 1-week history of a painful swollen left knee. On examination, the left knee is painful in all ranges of movement and is warm to touch. There is evidence of a boggy diffuse swelling and routine blood tests reveal a neutrophilia, raised white cells and pyrexia. Which one of the following investigations is the most important to perform? Excellent, guys, you get the idea. Joint aspiration. Now, you'll probably be doing all of them, except the skyline views of the knee. I popped that in for jokes. But essentially, joint aspiration is the most key here because you need to rule out septic arthritis, which can lead to destruction of the joint within 24 hours. Okay, someone's actually asked a question about the previous question. So if we just scoot to the, it was a few questions ago, wasn't it? How do you differentiate between Budd-Chiari and chronic liver disease? Now, I think the important thing here is to always look at the question. We're not going to give you any information that isn't there for a reason. Sometimes, okay, we pop in a few red herrings, but the key here is she's 68 with a history of cancer and she's come in with abdominal pain and distension. Now, with the smooth hepatomegaly and the fluid shift, that could very well be metastases, but then she's also got these abdominal veins that are dilated and the caput medusae. So that indicates a back pressure, which could very well be METs causing the back pressure if they're pressing on the hepatic vein. It hasn't told you anything about an alcoholic history, excess alcohol, anything like her having any other kind of peripheral stigmata of chronic liver disease, such as the asteriskis. I always find that one difficult to say. The palmar erythema, the spider nevi, etc. It's just given you the evidence of the back pressure. Okay. So going back to where we were, we just covered that question. Almost done, I promise. 64-year-old woman is seen by her GP for a very red, itchy and painful eye. She describes the eye as having the sensation of there being a bit of grit stuck in it. On further inquiry, she suffers from a dry cough and has trouble eating very dry food as she finds it sticks to her mouth and is difficult to swallow. Which one of the following diagnoses is the most likely? Okay, excellent. You've all got that. See, this is the reason I didn't want to include the title of, respiratory or rheumatology questions, because if you knew it was a rheumatology question, you'd know which the answer was. And obviously in the exam, they'll all be jumbled up so that there won't be that obvious pointer to the answer. So yes, this is describing Sjogren's syndrome, and anterior uveitis is associated with seronegative arthropathies such as psoriatic arthritis, colitis associated with enteropathy, reactive arthritides, ankylosing spondylitis. But in this case, you've got the dryness, and you wouldn't necessarily have the dryness with a case, anterior uveitis. That's associated with those conditions. Acute glaucoma, very important to know the signs of, and that would be a painful eye, again, red but not itchy, and you typically get a fixed and dilated pupil with that one. Retinal vein occlusion, you'd get worsening visual acuity, and if you look into the eye, it's a typical stormy sunset in appearance. But again, so the dryness here all points to Sjogren's syndrome. I think this is the penultimate question I have. 23-year-old man presents to his GP with an increasing pain in his lower back and stiffness that is worse in the mornings. He has noticed some intermittent pain in his knees and increasing pain in the soles of his feet towards the end of the day. A spinal X-ray reveals squaring of the vertebrae. Which of the following is not associated with this condition? So have a think. What condition is this describing, and what are its associations? Okay, I'm getting a mixture of B and E there. I think more of B. The answer is in fact B. Now with angstbond, this is describing angstbond. Always think of it as being associated with the 6 A's. So it's associated with apical fibrosis, associated with anterior uveitis, aortic regurg, amyloidosis, AV node block, and Achilles tendonitis. Think of it kind of from a head to toe format so you can remember them. HLA-DR4 is not the gene associated with it. It is actually HLA-B27, which is what also links it with psoriatic arthritis and the other seronegative arthritides that are associated with HLA-B27. HLA-DR4 is associated with rheumatoid arthritis and type 1 diabetes. Alrighty, a 10-year-old boy is brought to A&E with a limp. On examination, you note evidence of limb shortening. A lower limb X-ray demonstrates increased density in the femoral epiphysis bilaterally. What is the most likely diagnosis? Excellent. So most of you put B there, and it is B. Clues in the question, think of the age. With any of the PEDS questions, always think of the age ranges. Okay, so given that he is 10, this is leg calf Perth's is quite common in boys of this age. It's also bilateral, and so that's what the answer is. Developmental dysplasia of the hip, I'd be thinking in an infant. Septic arthritis in someone who either is an IVDU or has recently had a joint prosthesis put in. Okay, so yeah, always do think of the age range with PEDS questions. Brilliant, and that's all I've got for you.
Thank you to everyone who's made it this far. I'm Andrew. I'll be doing some endocrinology, some neurology, some dermatology questions. So a lot of the niche and the nitty gritty, but let's see how we do. So the first one, I'll read them out, but I won't read out the blood tests. So a 73-year-old gentleman was admitted to hospital after falling at home. On examination, the patient sustained no obvious external injuries, and CT head and chest X-ray were normal. Admission tests, which you can see. The patient remains hemodynamically stable with no evidence of dehydration and no evidence of overload. What would be the most suitable medical management for this patient's hyponatremia? And I'll give you 30 seconds.
We'll just give them about 5 more seconds and then.
Okay, I think we've got some B's, haven't we? That's pretty good. So the correct answer, of course, is B. So this, I've highlighted some of the important stuff here. Obviously, the sodium is low with a normal potassium and no abnormalities in urea and creatinine. We've got a few hyponatremia screen type investigations on the right table, and the most notable change is, of course, a high urine osmolality and a high urine sodium. So the way I like to think about hyponatremia, I'm sure everyone teaches it differently, is we need to think about the patient's fluid status. And I've actually got a nice table, which I drew here quickly. So, of course, if a patient is hypovolemic, they could be very dehydrated. They could be losing their water and their ions through something like burns or GI loss, or obviously in their kidneys through diuretics or Addison's. On the other hand, if they're hypervolemic, they could be taking on a lot of excess water or retaining water because of cardiac failure or kidney failure. And then for this kind of patient where they're euvolemic, they're not dehydrated, they're not overloaded, we need to think, why is their urine osmolality high? Is there a lot of water being reabsorbed back from the urine into the blood? In which case, it's probably SIADH, right? And the way that we manage it is through fluid restriction and sometimes giving them a bit of sodium on the side. Okay, good. So, next question. A 65-year-old lady is brought into ED by her family, who reports she's lethargic, confused, and has experienced weight loss of over 10 kilograms over the past few weeks. On examination, the patient is clinically dry, with a heart rate of 112 and a blood pressure of 106/65. The nurse tells you that when testing for blood glucose, using the capillary reading, the result returns as high. The patient has a chest X-ray in the resus room, which shows some consolidation. Which of the medical management options should be initiated immediately? And there's a nice table of blood tests again. So another 30 seconds. Okay, I think we're getting some responses, which is good. Good. Okay, everyone's saying C. Fantastic. See, I thought these questions were hard, but you guys seem to be doing pretty well. So the answer is, of course, C, IV fluid therapy. So this patient has significant weight loss, which is probably due to dehydration, and they have a pretty bad AKI going as well, which is probably a result of that dehydration. Their sodium is slightly high, and they do have a high serum osmolality if we just look at the bloods in general. And of course, the HbA1c shows they have uncontrolled diabetes. This is a really typical history for HHS, and the main problem is that the patient is significantly dehydrated with this condition. So we need to give them aggressive IV fluid therapy. I think some trusts say you give the first litre of fluid in the first hour, and then the next litre of fluid in the next 2 hours, and the next litre of fluid in the next 4 hours. But because this patient has lost over 10 kilograms, there might be over 10 litres fluid deplete. So we do need to give them a lot of fluid very quickly. Okay. And let's see. Oh, when would you give sodium in the last scenario? Good. So for SIADH, fluid restriction is probably the mainstay of management. You can give sodium, you don't have to. Sometimes we just advise patients to take a bit of salt with their meal, but especially in very refractory SIADH, where it's not responding to just conventional fluid restriction, we can either, well, we can give them actually sodium chloride tablets, so literally tablets of salt, which we just advise them to take. So it's a plus minus sodium intake, but fluid restriction definitely, and it kind of depends on how low the sodium is and how refractory it is to current treatment. Okay. So the next one, a 45-year-old woman presents to her GP with generalized muscle weakness and fatigue with blurry vision. She has a background of arthritis and well-controlled diabetes. On examination, the patient appears to have prominent interscapular adipose deposition and facial plethora. Blood pressure is a bit high. What diagnostic tests would be most appropriate to clarify your top differential? So 30 seconds once again. Okay, good. We're getting some D's. I agree with you. So the correct answer is, of course, D, the dexamethasone suppression test. So the history for this patient, the generalized muscle weakness, which could be proximal muscle weakness. She's got the interscapular adipose, which is the fancy way of saying buffalo hump, and facial plethora, which is a fancy way of saying moon face. And the high blood pressure contributes a bit as well towards your diagnosis of Cushing's. Of course, what we want to know is Why does she have corticosteroid excess? Is it due to some endogenous production? And I know it says she had blurry vision. If it said bitemporal hemianopia or something like that, I may be thinking, oh, there might be a pituitary problem where there's too much ACTH. But, you know, the patient has arthritis as well. It's conceivable that she could be given steroids to treat her arthritis. So we need to clarify if there's some kind of breakdown of the patient's own negative feedback or if there's some exogenous steroid. And the main way to differentiate between the two is with the dexamethasone suppression test. There's a lot of fancy endo tests there. So the ARR for aldosteronism, the short synacthin for adrenal insufficiency, and your glucose tolerance for diabetes. Okay. Okay, so next one is neurology. So a 65-year-old woman, another one, presents with vertigo and ataxia. Upon taking a further history, the patient reports having a central headache and problem swallowing. You perform a cranial nerve examination, revealing unilateral miosis and ophthalmos diplopia and a hemifacial loss of pain and temperature sensation. A CT head is ordered, which confirms the diagnosis of ischemic stroke. Which vessel is the most likely location of the infarct based on the patient's symptoms and exam findings? Okay, we've got some responses. They're all B, and I agree with you. Congratulations. I think stroke syndromes, apart from the really obvious ones like your middle cerebral and your posterior cerebral, there's quite a few niche ones. I would say this patient has a lot of cranial nerve problems, the problem swallowing, the potentially kind of cranial nerve 3 and definitely cranial nerve 5 problem. They have vertigo and ataxia, which it could be cranial nerve 8, it could be cerebellar. And when I see cranial nerve problems and cerebellar problems, I think posterior inferior cerebellar artery. This is actually a good representation of a stroke syndrome called the lateral medullary syndrome or Wallenberg's syndrome. And that's usually associated with posterior inferior cerebellar artery stroke, which is a mouthful. Someone said D. So especially in SBAs, the posterior cerebral artery is usually associated with visual changes like cortical blindness and homonymous hemianopia. They're the main two that you tend to hear about. And with the anterior inferior, SBAs usually talk about hearing loss, and I'll show you why. So the circle of Willis, which I'm sure everyone is sick of at this point, the AICA has this branch called the labyrinthine artery, which actually supplies cranial nerve 8 and the inner ear. So if you have an infarct of the AICA, you'll most definitely get hearing problems and potentially vertigo and balance issues too. With the PICA, this goes over the lateral medulla oblongata, where the cranial nerves are, and then wraps underneath the cerebellum. So you get your cranial nerve issues, and then you get your cerebellar signs. Okay. So next question. A 23-year-old woman attends the epilepsy clinic, requesting a change in her anti-epilepsy medication. Her seizures started several years ago, where her partner noted episodes of her staring into space and making lip-smacking movements, which could occur when she was awake or asleep. She was started on carbamazepine, but wishes to change medications as she has been experiencing severe dizziness, nausea, and vomiting whilst taking the medication. So what, according to current guidelines, should be trialed next to manage this patient's epilepsy? Okay, interesting. There's a lot of C, there's a lot of B actually. So for this question, according to guidelines, it's actually D, it's lamotrigine. So B ethosuximide is usually used for absence seizures. Now, this patient, she does have the staring into space, which could imply impaired awareness, but she has these gestural automatisms, which in my opinion is much more likely to be a partial seizure. It's kind of a typical description of a frontal onset epilepsy, if you agree with me. So frontal onset epilepsies, your partial seizures, we're thinking carbamazepine is the first line or lamotrigine. So in this case, because the patient can't tolerate carbamazepine, we should switch to lamotrigine. I put an arrow for sodium valproate saying first line for generalized seizures, but just be aware for a 23-year-old woman, if you were to give sodium valproate, you wouldn't give it first line. The reason being is that sodium valproate is very teratogenic, and whilst technically all anti-epilepsy medications increase the risk of birth defects, sodium valproate has some legal restrictions behind it. So it's first line, but maybe not first line for this lady. Okay, and I've put this nice table. So again, I guess the staring into space might have tripped some people up into thinking it's absence seizures, which would be generalized onset, but I think the automatisms make it seem more focal onset, probably impaired awareness. Okay. Next question. A 4-year-old girl is brought into the emergency department by her parents. They reported that she had a fit, which they described as muscle stiffness followed by a rhythmic jerking of all 4 limbs, lasting for 1 minute. She was sleepy for 20 minutes following the episode. On examination, she has chicken pox with the typical rash, a high fever and coryza. There are no signs of meningism. GCS is 15 and the patient is hemodynamically stable, and there's no past medical history of note. Admission bloods are unremarkable apart from raised inflammatory markers. So what would be the most appropriate initial management for this patient? Oh my goodness, there are fast responses there. Very well done. They're all saying E. Okay, fantastic. So you're right, of course. Reassurance and safety netting only. This is a really typical history of a GTCS precipitated by this high fever and chickenpox. It's a simple febrile convulsion, and simple febrile convulsions are, of course, managed conservatively in the first instance. It's a thing that if you know it, you know it. But any simple febrile convulsion, if there's no focal neurology, no prolonged seizure, then we can send the patient home, of course, with safety netting and advice. Next one. A 45-year-old gentleman attended his GP reporting muscle weakness, lack of coordination and fatigue. He first noticed this as he kept tripping over his feet whilst on his daily jog. He's otherwise fit and well with no past medical history of note and does not take regular medications. You perform a neurological examination on him, and I'm not going to read out the whole table, but what's the most likely diagnosis based on the patient's history and clinical findings? Okay, good. We've got some fast responses once again, and they're all B, and I agree with you. So for this patient, there's some upper and lower motor neuron signs. So you have your Babinski positive and your tongue fasciculation circulations. And you've got neurological signs at multiple levels as well. And when you see a presentation like this, it's very suspicious for motor neuron disease, or it's at least something that you need to investigate. So let's see. Motor neuron disease affects both the upper and lower motor neurons, and that's why you get this mixture of signs. And interestingly, tongue fasciculations, at least anecdotally and on some papers, are quite specific for motor neuron disease, which is interesting to note. Oh, there's a question here. It says, how do you tell the difference with absent seizures and focal seizures? Okay, so absent seizures are a specific type of generalized seizure. By absence, what we mean is that usually you see them in children. It kind of looks like they're staring off into space and not doing anything. They're unresponsive to you. So a lot of the time, if they're in school, the teacher would just say, oh, they're daydreaming, they're not listening to me. It's that kind of history. A focal seizure, though, it depends upon where the epileptiform activity exists. So for the frontal lobe seizures, we tend to get our automatisms, our lip smacking movements, because of course the motor cortex and the motor programs are within the frontal lobe. It's not usually just staring off into space, unresponsive by itself. And then remember things like parietal lobe seizures. If they're focal, that's where you have your sensory cortex mainly. So you get your weird skin tingling or electric shocks on your SBAs, or a feeling of floating or moving through water. And then you've got your temporal lobe epilepsy, which is your most common type of focal seizure, where you get your strange déjà vu or jamais vu type experiences. And often the patients say, I don't know how to describe it. It's like changes with memory and aura, which is interesting. And of course, occipital lobe is rare. You can get some visual changes, especially from there. But absent seizures is a very specific history, usually in children. They're staring off into space, they're unresponsive, and they don't know the seizures happened, and it's almost like they're daydreaming. But you'd correlate it with your other signs, like epileptiform activity, or I guess there's no post-ictal phase actually with absent seizures, which is interesting as well. But yeah, you'd correlate it with your epileptiform activity and other signs, which would point you towards a diagnosis of absent seizure. Okay, so next one. Okay, this is dermatology now. So an 18-month-old boy was brought to the GP by his parents as he had developed a widespread rash across his body, limbs and face. The rash had first appeared 1 day ago and is formed from mildly erythematous macules across the entire skin surface. The parents report that the patient had not been itchy, although he seemed to have a runny nose. Apart from the rash, the boy was fit and well, he was just running around. They also report that their son had just recovered from a high fever of 40.1 degrees, which had lasted for 3 days, but he was currently apyrexial. So based on the parents' description of the patient's history, what's the most likely cause of the patient's rash? Okay, we're getting some responses, very good. So B or E and E and lots of D's. So the correct answer is, oh, I've got a nice picture actually, that's good. So this is a nice picture demonstrating the rash. So it's very prominent, in this case, macular rash on the limbs. But the correct answer is D, it's roseola infantum, or the so-called 6th disease. Now the history kind of gives it away, I think, in this case. So especially someone who's around 18 months, a high fever for 3 to 5 days, which goes away, and then suddenly they get this whole body macular rash, which isn't itchy or anything. That's a very typical history for roseola infantum. It's one of the viral exanthems of childhood. There's 5 of them, and they're labeled 1 to 6, which is confusing because there's 5 of them. But I've got a table here showing you them. This is from an online textbook, which I've written there. We can see the 5 main ones are measles, and on SBAs, always look out for features like Koplik spots, so your white spots on the oral mucosa's inner surface. Your second one is scarlet fever. Remember your strawberry tongue there on the SBAs and this fine sandpaper-like rash. Your third one is rubella, so your rose, pink and maculopapular rash. Disease number 5, as we skip over 4, is erythema infectiosum. This is the so-called slapped cheek rash. So on the SBAs, always think about your very erythematous cheeks. And then your 6th one, roseola, your maculopapular or macular rash, associated with a high fever. There's some other childhood viral exanthems like varicella or chickenpox, which I'm sure everyone is familiar with, a vesicular rash, and hand, foot and mouth disease caused by Coxsackie, where you have your vesicles on the hands, feet and mouth, as the name suggests. Okay, the next question. A 70-year-old man presents to the ED with signs of community-acquired pneumonia. As the patient takes off his shoes, the nurse alerts you to the presence of an ulcer on the sole of the left foot, beneath the metatarsal heads. The ulcer measures 2 by 2 centimeters. It has a punched-out appearance with no evidence of surrounding erythema or swelling. The base of the ulcer appears pink and a probe can't reach the bone. Notably, the patient has very poor sensation below the level of the ankles and all the modalities tested. The patient has a past medical history of type 2 diabetes, but he tells you, oh, I can control it with my lifestyle. However, his HbA1c is 100. So what's the most likely type of ulcer based on the history and examination? Okay, we've got a bit of contention between C and A. I've got a nice picture on the next slide. It was hard finding a suitable image, but this is kind of the appearance of the ulcer. Okay. Sorry for anyone who's eating, but the correct answer is C. It's a neuropathic ulcer. So there's a few things in this massive wad of text which point towards neuropathic ulcer. Of course, the patient has poorly controlled diabetes, biochemically speaking. They have this diabetic neuropathy, the poor sensation below the level of the ankles in all modalities. The ulcer itself is punched out in appearance, and its location is quite suspicious as well. It's beneath the metatarsal heads. It's a very common pressure point at the bottom of the foot. And it's a common site for neuropathic ulcers, as well as things like the soles and the heels. I think the description of this question, the way that the nurse tells you and the patient doesn't even know about it, kind of also points towards a neuropathic ulcer. So neuropathic ulcers are painless, whereas arterial ulcers, which is A, are very painful. I think for an SBA, if they're trying to get you to talk about arterial ulcers, they'll probably mention the fact that the feet are cold or pale or pulseless. I think those are the main kind of things. The arterial ulcers tend to be quite deep as well, and I guess punched out appearance could, it can kind of be a bit of a distractor. But yeah, the nature of the ulcer's discovery, the diabetes and the neuropathy, in my opinion, all point towards a neuropathic ulcer. Okay, the next one. 17-year-old girl presents with a blistering rash on her elbows and knees. She has a complex past medical history, including Addison's disease and autoimmune thyroid disease, although they're currently well controlled. On examination, the patient is thin but systemically well. There's prurigo and clusters of itchy vesicles on the elbows, knees and shoulders with scabbing and scarring. The lesions are symmetrically distributed. The patient also has aphthous ulcers. A skin biopsy is taken, revealing IgA deposition within the skin. Bloods reveal mixed anemia secondary to iron and folate deficiencies. So how would we manage this skin condition? And this is the last question, by the way, from me. Okay, good. We're going strong with the D. And I agree with you. That's the correct answer. So this, I think, is a pretty mean question. So I'm glad that you guys have got it right and so quickly. There's a lot of things which point towards what's going on here. The patient has an autoimmune history. The nature of the rash is very itchy vesicles and they're symmetrically distributed. They're scabbing and scarring, probably just from the patient popping the vesicles. Then we have ulcers, IgA disease, and dietary deficiencies, which are all features of GSE, or gluten-sensitive enteropathy, aka celiac disease. So the rash here, which is a skin manifestation of celiac disease, is something called dermatitis herpetiformis. And it's herpetiformis not because it's related to herpes or viruses, but because this rash occurs in clusters. And because it's a manifestation of an underlying celiac disease, the way to manage it would be to manage the celiac disease, which is through strict dietary restriction. Of course, we give the patient dapsone cream in the short term to help with the itch too. Okay. Unfortunately, I don't have a picture of this one because there weren't any good copyright-free ones. But oh dear. Okay, well, I think I've accidentally ended it, but yes. But usually it's a very aggressive red-looking vesicular rash, which is symmetrically distributed, can occur on the elbows, the knees. It can also occur on the shoulders and the chest, actually. So it's definitely one to have a look at. Okay. So that's all from me. If there's any questions, I'll take them now. Otherwise, we'll move on. Oh, I think there's one of them. Okay, punched out is a red herring. So, interestingly, neuropathic ulcers can be very deep. They can be so deep sometimes that if you put a probe in them, you'll hit the bone. And that's when a patient's at risk of osteomyelitis. They can look very punched out in appearance indeed. So both arterial and deep neuropathic have that appearance. I wouldn't say it's a red herring, but it might make you think arterial, but the rest of the history points towards a neuropathic ulcer, and punched out is consistent with neuropathic ulcer as well. Are arterial also at risk of osteomyelitis? Interesting. I mean, if it's deep enough, feasibly, yes. But typically, a patient with diabetes has an impaired immune system anyway. They're much more likely to get these deep-seated infections and nastiness. But yes, they could potentially be at risk of osteomyelitis in the arterial ones. Okay, I think that's all from me.
Oh. Hi guys, I'm Ash. So I'm also working in London. So I'll be going through psychiatry, elderly care, hematology and renal, and there's a few pediatric questions just kind of dotted around in there too. Cool. So we've got a 33-year-old woman who's admitted on the surgical ward with alcohol-induced acute pancreatitis. She's been given paracetamol, IV fluids and antibiotics. During the second day of admission, she becomes very agitated and newly confused. She's trying to pull out her cannula. The nurses managed to get some obs on her. So her respirate's 20, heart rate's 105, BP's 152/91, and temperature's 38.1. go to assess the patient and you see that she looks very confused, she's agitated and shaky. She's clammy and she's trying to get out of bed and leave. What's the correct management for the likely cause for her acute onset confusion and agitation? And if anyone wants to put in what you think she might have, it'd be great as well. Just wait 10 more seconds. Okay, so you can see in the chat that most people put down D, put down delirium tremens. So, yep, that's right. So, I'll go through this and then I'll go through the diagnosis. So, the correct answer is Prapanex and chlorodiazepam oxide for alcohol withdrawal, delirium tremens, etc. Just going through some of the other options. So, lorazepam is usually used as sedation. It's a benzo, so it's used for convulsions as well, and also any sort of stimulant poisoning, so things like amphetamines. Naloxone is used in opioid toxicity. You can give activated charcoal within 1 hour of ingesting any kind of substance, so like aspirin, any antidepressants or benzos. And then flumazenil is used for any overdose of benzodiazepines. And then the Prapanex is usually given to prevent any sort of peripheral neuropathy and prevent it from developing into like Wernicke's encephalopathy. And chlorodiazepam oxide is there to kind of counter the withdrawal by kind of acting on the GABA receptors, which alcohol usually goes and reacts on. Cool. So in terms of her presentation, so she had, there's a risk of getting seizures from sudden alcohol withdrawal. So she doesn't have seizures, but she does have this kind of mild to severe withdrawal going on. So her presentation was that she was quite agitated. She's got tremors, tachycardic, hypertensive as well. She had a raised temperature. So it's it doesn't really state a clear picture of paranoia, but she is definitely disorientated and confused. So it's kind of this mild to severe picture going on because she hasn't been vomiting. Cool. So you got a 22-year-old female, Josie, who's fired from her job as a waitress recently. Her mother brings her into the GP concerned about her recent behaviour. She's been keeping to herself mostly, rarely talks to the family, stopped playing tennis and spends her time locked up in her room all day for the past 2 months. She was fired because she started throwing food at the customers. The GP assessed her further. Josie avoids eye contact. Her speech is fast and detailed. She states that people can hear her thoughts and that everyone around her is using this to plot against her and get her fired. So which symptoms are present in Josie which may lead to a diagnosis of schizophrenia? So again, I'll give you about 30 seconds. Okay, so E seems to be the winner, and that is the right answer. So she's got this kind of thought broadcasting because she feels like everyone can hear her thoughts. The way she's speaking is fast and she's got a lot of detail in there, which is the pressured speech. She's got this idea that everyone's plotting against her, which is the persecutory delusions. And the anhedonia, so she's not really into any of the other things that she used to enjoy, like playing tennis, and she just spends time on her own as well. So she has that withdrawal as well. So This is the DSM-5 criteria for schizophrenia. So usually you need about 2 or more of the following for a significant time. So it's usually about a month. So delusions, hallucinations, any kind of disorganized speech, and any disorganized behavior, and the negative symptoms as well. So like the withdrawal, anhedonia, things like that. And one of the other key things is that it's affecting their kind of normal day-to-day life. So in this case, she's not able to keep a job, she's not really interacting with her family or doing anything, and she's basically paranoid about everyone around her. My slides are moving. Okay, cool. So I've just put these tables in here because I thought they were quite useful to help kind of get a better idea of what the different thought disorders were, and also just to go through the different speech ones. I'm not going to go through it now because of time, but it's in the slides. Okay, next question. Got a 34-year-old man who's lost the will to live and decided to mix his antidepressants with excessive alcohol intake. He is taken to ED and treated. He is now medically fit, but is very low in mood and is hopeless about the future. You're worried about letting him go home, and he lives alone and fears he may not he may attempt to end his life again. What would the next best step be? Again, 30 seconds. Okay, so mostly B's in here, which is right. So this patient is clearly at risk of attempting suicide again and likely to end up back in ED. So before you discharge them, you would want a psychiatric evaluation, and this will kind of help assess the risk and form a more appropriate management plan for them to prevent them from attempting it again. Cool. Just in terms of the other options, you wouldn't stop his antidepressants, probably would make him worse, unless he started his antidepressants quite newly, because when you first start your antidepressants, you can get there is a risk of becoming more suicidal. So you might want to check that, but you wouldn't stop it. It's more just monitoring and reassuring them that that phase will pass. Again, you don't want to advise them to go to see their GP and about alcohol cessation, because it's not really going to help the bigger picture here, and likely the patient's not going to go and see the GP. Waiting for an alcohol liaison nurse, again, not going to be helpful here, and outpatient psychiatry follow-up. You probably will end up with one, but that's not the best next step here. So next question. So we've got an 82-year-old gentleman who's admitted to the hospital following worsening frequency of falls over the past year. In the recent week, he has had 11 falls. He was independent with all ADLs, but has been slowing down and has become housebound. Past medical history includes hypertension. Bloods, ECG, and chest X-ray are unremarkable. They were referred to the elderly care ward. When examined, the patient has some cogwheel rigidity, hypomimnia, and hypophonia. They were diagnosed clinically with idiopathic Parkinson's disease. Which medication will be first line for this patient? So I'll give you 30 seconds to put your answers in the chat. Okay, so The answer is D. So we have your first line management, which is your co-phenyldopa or co-caraldopa. So this is a combination of your levodopa and your carbidopa. So your levodopa is your dopamine. So it's a precursor to dopamine, and it then gets metabolized into dopamine to act on the dopamine receptors. And we give carbidopa because it inhibits the metabolism of levodopa peripherally, so you don't get these peripheral side effects. Nicotine patch isn't indicated here because the patient's still able to swallow. There's no indication within the case itself anyway. So we wouldn't really consider a patch unless they were having difficulty swallowing. The other one, you don't give levodopa on its own just due to the side effects that you can get with it. Now, if a patient doesn't have any, like if the Parkinson's isn't affecting their normal ADLs, then you would maybe consider giving roperidone, or you can give nicotine as well. And that's usually if it's like mild symptoms and they can just carry on with their normal day-to-day life. It just kind of gives them a little bit more comfort. So that's why A is wrong. And also you don't give co-carbidopa, which is your levodopa with the carbidopa with the roperidone, as first line. And then this was just there to throw people off. So co-carbidopa doesn't exist as a name. And then levodopa with co-carbidopa is also kind of the brand name that you could look out for around here is Cinemet. Okay, so moving on. And then I just put this slide in because I thought it was quite useful just to cover what you would do in a falls assessment. So it's always important to check what their comorbidities are because that could be a cause. Ask them about the mechanism of fall and if there's any complications. So example, if they'd hit their head, if they'd had any loss of consciousness or anything, if they lost, if they'd noticed any sort of auras, anything like that. And then do a full systematic review, going head to toe. So all your neuro stuff, cardio arrest, abdominal, genitourinary as well. Check the fluid balance and also ask them about their living situation because there's always kind of environmental hazards as well, such as tripping over carpets is quite a common cause. And you would do the whole battery of investigations with bloods, urine, dip and analysis, do an ECG, and you might need to consider a 24-hour tape and an echo as well on top of that. Get a bladder scan, do a PR if that's indicated, and I think most people who come through A&E always get a chest x-ray. They've had a fall and it's indicated, they'll get a CT head automatically as well. And then any other special tests, looking for any other signs. Management is mainly to treat the cause of the fall. So in this case, it was actually progression of Parkinson's disease, which hasn't been diagnosed, which was causing the fall. That be treated and hopefully we'll get some improvement. Next question. So you got an 83-year-old woman, Mrs. Tanner, with a history of type 2 diabetes and hypercholesterolemia, who's found wandering in a neighbour's driveway. When a neighbour tries to converse with her, she insisted that it was her daughter's house. She seems very restless and agitated and felt warm to touch when the neighbour tried to guide her back home. She last saw her daughter 2 days ago when she came to pick up her children, and she was completely fine. Mrs. Tanner is recently widowed and lives alone. She is independent of ADLs and usually looks after her grandchildren after school and helps them with their homework. What is likely to be the underlying cause for her confusion? So I'll give you 30 seconds. Okay, I'm getting a mix of B's and C's here. So the answer is actually B. So she's more delirious. So this is more of an acute onset because 2 days ago she saw her daughter and she was completely fine, and she seems quite independent and very with it from the history. So it's very unlikely that within 2 days she would have any sort of dementia-like picture, because those are more gradual progressions. So delirium's the right answer here. In terms of depression, again, she may or may not be, but it wouldn't be a sudden onset of this confusion. And then I just put this in here because it was quite useful just to differentiate between dementia and delirium. So your dementia is more of an insidious, slow progress. Delirium, it's acute, it fluctuates. And then this is a really useful mnemonic here, pinch me, so causes of delirium. So pain, infection, so likely she has an infection, she's spiked to temperature. Nutrition, so any foods, constipation, so quite a big one in elderly people. Hydration, so a lot of the elderly don't drink enough, they end up being dehydrated, end up being delirious from that. Medication as well, so polypharmacy is a big thing with old people as well. So sometimes there's interactions between different medications. They might have been started on something, they might not actually be taking their medications properly either for various reasons. So that's something you want to consider. And then just environmental factors too. So sudden changes in the environment can disorientate a patient too. Cool. I just put this in there just for your revision, just kind of going through the steps of treating delirium. I'll let you guys read that in your own time. So, next question. A 68-year-old woman visits a GP complaining of hip pain. She has known arthritis in her knees. She also has generalized aches all over her body. So past medical history includes type 2 diabetes controlled with metformin, x-rays done, and it shows osteoarthritis changes. Which of these is used to assess the risk of future fractures in patients? So I'll give you 30 seconds to think about it. Cool, so we are getting loads of B's in, so that is the right answer, so FRAC score. So this is basically the assessment tool, and took a screenshot of the page there, just to go through. And you also have a look at the T-score from the DEXA scan as well. And the main thing with the FRAC score is looking at the risk of a hip fracture or any kind of arm or spinal fractures within the next 10 years. And then it's kind of split into risk of a hip fracture, and if it's more than 3%, you consider treatment, or any kind of osteoporosis related fractures, so your arm, spine, other fracture, body parts as well. And if that's more than 20%, again, you would consider treatment. And in reality, you end up doing all of this, but the FRAC score is the main one here. And just quickly going through your DEXA scan, so use a T-score. So normal bone density is between +1 to -1. Then low is -1 to -2.5, and if you high risk of osteoporosis, then it's -2.5 or higher. And at that point is where you really consider kind of treating them. So usually giving like bisphosphonates and maybe like vitamin D, calcium supplements as well. Again, just put this in as little notes to help you with the revision. So going through the risk factors for any sort of fragility fractures, and also different managements. So that's usually your first line, giving them supplements and also lifestyle modifications. And then if they're high risk, again, like I mentioned, bisphosphonates, so things like aldosterone. Cool. Okay, next one. So, got a 98-year-old woman who comes into hospital following a fall with no loss of consciousness. She has a tender and swollen right wrist. She has an X-ray and it shows that she sustained a Colles fracture. She's out in a cast, and the doctor takes an extensive history from her to decide what pain management she needs to ensure that there is no interactions. She states that she takes ramipril for her hypertension and metformin for her type 2 diabetes. Both are well controlled. She's otherwise very independent of her ADLs. She only uses a stick when she goes to the local library knitting club twice a week. She does have some help with the shopping, but she is a bit slow now, and it's a bit too much work for her and tires her out. But otherwise she's able to look after herself. What is her score likely to be on the clinical frailty scale? This is a bit of a mean question, but just have a go. I'll give you about 30 seconds again. Okay, I can see a few people have put C in here. This is a very mean question. If you've not really memorized the frailty score, you wouldn't find it that easy to do this. So answer is C. Well done, getting that right. So the scale goes from 1 to 9, 1 being very fit and healthy, no comorbidities really for their age, and then 9 is terminally ill with a reduced life expectancy of like less than 6 months. So in this case, she's 4 because she's not dependent on anyone else for most of her activities of daily living, but she does need some help with shopping and things like that. She's complaining of being slow as well. So that's where she kind of falls into this vulnerable category. She doesn't really need any help with any other things like housework or dealing with their finances. She still seems to be like going out and things on her own anyway. So that's why she doesn't come into 5. And then she is managing well, but because of the fact that she needs a little bit of help with the shopping and things, she's not 3, she's 4. Oh. Just got a question about how many questions there's left. So it goes up to 50, so there is 7 left. Okay, next question. So we've got a 76-year-old gentleman who's admitted due to chest pain, shortness of breath and nausea. He's been feeling generally unwell for a week. Bloods are sent off and an ECG is done. Which of these drugs is a culprit for his condition? I'll give you another 30 seconds. Okay, so we're getting a bit of a mix of answers here. So mostly C's in here though. So the answer is C. So it's spironolactone, it's potassium sparing. So from the bloods you can see that the potassium is high. This ECG is showing changes due to the hyperkalemia. So you can see these tall peak T waves here. Most of the other bloods are actually within range, so wouldn't be worried about that. It's the potassium that's the main thing here, and spironolactone is the only one which is the main culprit. Okay, and the other ones don't have any indication of any hyperkalemia, and salbutamol itself is used to treat it. So I've just put this in here. So you've got different ranges for potassium levels. So from 5.3 is the higher threshold. Anything up to 6 is mild. 6 to 6.9 is moderate, and severe is anything above 7. And your ECG changes usually occur kind of when you've gone above 5.5. So in terms of treatment, you usually treat it if you see any ECG changes, or if it's above, I think it was 6.3 is what I want to say, is when you definitely treat it. I haven't put treatment in here. So in terms of treatment of hyperkalemia, you'd give them nebulized salbutamol. You give them an infusion of 10 units of insulin in glucose or dextrose, and then you'd also consider calcium gluconate if it's above 6.3, or if there's any ECG changes, just to stabilize the cardiac membrane. So next question. Got a 17-year-old boy who presents with a recent history of 3 days of hematuria. He has no pain and is otherwise feeling well. He suffers from asthma but is otherwise generally fit and healthy. He mentioned he did recently have a bit of, he did feel a bit fluey, but has recovered now. General examination is unremarkable. Urine dip is done by the GP and is positive for blood and protein. What is the likely diagnosis? So I'll give you another 30 seconds. Okay, we seem to have a bit of a tie between C and B. So the answer is actually C. So it's IgA nephropathy. So this is a nephritic syndrome. That's usually the most common cause of glomerulonephritis. So you usually end up with blood and protein in the urine dip. And then if you do a urine analysis, you'll get these red cell casts as well, which kind of indicates there's something going on with the glomerulus. Just saw in the chat, is it due to visible hematuria? Yeah, that's why. And then just add to that, it's usually related to some sort of upper respiratory tract infection or any GI infection as well. And it's quite you need a recent history of an infection. So I think on the next slide, yeah. I put this table in just kind of comparing nephritic and nephrotic syndromes, because I quite like tables and I'm quite a visual learner, so thought that would be useful for you guys. The main thing is in nephrotic syndrome, I always think it's got an O in there, so everything's a bit more oozy, so you get all this edema and a much more protein in the urine as well. Whereas nephritic, it's more to do with the fact there's hematuria. And you might get a bit of edema, but it's not as prominent as it would be with any of the nephrotic syndromes. Again, just a little slide that I put together just for your revision as well, which you can look at it in your own time. Next one. So you got a 72-year-old man who comes into hospital following a fall with a head injury. He's confused and he's been lying on the floor for almost 10 hours before he was brought to the hospital by his son this morning. There are no medical records for this patient, and the son reports that he rarely goes to the doctors. You do a battery of investigations. Creatinine is raised. You consider whether this is an AKI with rhabdomyolysis or possible undiagnosed CKD. Which of the following findings will favour a diagnosis of CKD over AKI? So I'm going to give you about 30 seconds. Okay, so mostly A, got a couple C and got a C and a D in here as well. Check and see why. But the answer is C because it's more specific. So creatinine kinase would be raised if it was rhabdomyolysis and the myoglobin released would cause the AKI because it's nephrotoxic. So if they did have an AKI, it wouldn't be due to that, but it's still possible to have an AKI here. In CKD, you end up with a reduced calcium, elevated potassium, reduced bicarb, and also an anemia picture as well, because the kidneys play a role in regulating all of these processes. The fact that they've got a decreased calcium kind of pushes you towards more of thinking that it might be a CKD picture because it gives you this kind of chronic picture instead. Same with the anemia as well, but anemia could be due to anything else as well. So this is why the adjusted calcium being decreased is the best answer here. They've also got a raised inflammatory marker, so your CRP. So they probably do have an underlying infection going on here, which is probably why it could have been one of the reasons why they fell. And then again, this is just a table comparing an AKI to CKD. So I'll let you guys read that in your own time. And then again, just quickly going through the functions of the kidneys. So it regulates your red blood cells. So you check on with the FBCs, you can get a normocytic or a microcytic picture because you usually typically end up with some sort of iron deficiency anemia. Your vitamin D is processed in the kidney, so checking your bone profile, so your calcium levels to see if there's any like dysregulation going on there. Again, Usinase, checking your potassium mainly, but also just general kidney function with the Usinase. And again, your acid-base balance is also done by your kidneys. So looking at your bicarb is a good thing as well, because bicarb is produced in the kidneys. Almost getting there. Well done for sticking on. So got a 35-year-old woman who's admitted into hospital due to severe pain. She has loin to groin pain, which started 2 days ago and has been worsening. She's vomited twice today. So her rest rate's 22, heart rate's 98, blood pressure's 111/69, and she's saturating at 99% on room air, and her temperature is 38.2. So her blood show increased inflammatory markers, urine dip is positive for proteins, nitrates, leukocytes, along with trace blood. Urine analysis shows some white cells present and cultures are pending. A CT shows a parenchymal enlargement, small fluid collections and linear streaks of gas. What is the best management plan for this patient? So again, I'll give you about 30 seconds. Okay. Okay, so the correct answer here is C. So I just saw a question in here, says, how do you tell if she has renal colic or pyelonephritis? So the fact that she spiked the temperature here points towards pyelonephritis. With renal colic, she's very unlikely to have a fever, though she may have stones which can then develop into pyelonephritis as well later on. But the main thing here is that you want to treat her pyelonephritis. So you want to treat her with co-amoxiclav and give her some paracetamol, and you'd also add on fluids on top of that too. Okay. And just in terms of treatment, co-amoxiclav is usually the one that you give. In pregnant ladies, you would give cefalexin, and then trimethoprim and ciprofloxacin are just other options that you have. And fluids are quite important here. And the main complications are you can develop AKI, end up with an abscess, or even develop sepsis. And you also are at risk of having recurring infections as well. Okay, next question. So a 45-year-old gentleman with metastatic lung cancer is admitted to hospital due to feeling generally unwell. He's currently receiving palliative chemotherapy. He's spiking a temperature of 38.2. His heart rate's 102, blood pressure is 99/60, and his stats are 94%. On examination, he looks pale and seems very drowsy. So bloods are sent off. These are the results below. His chest X-ray shows no significant changes. Urine output is minimal, and the abdomen is soft, non-tender. The patient does have some tenderness and erythema around the PICC line. You suspect sepsis. Which is the likely findings on bloods seen for this patient? Give you 30 seconds. I do see a question in the chat. I'll answer that after this. Okay, so the answer is C. So I'm glad no one got thrown off too much about this. So this is kind of pointing towards more neutropenic sepsis. So in anyone, especially anyone with a metastatic cancer, you would kind of want to look out for this. So criteria for neutropenic sepsis is it's less than 0.5. So here it's 0.2. The white cells can either be raised or it can be normal. So that's mainly because of the neutropenia. They have a fever, which is above 38. He's not, he is hemodynamically unstable. He's got altered GCS, so he's confused. I think it was, yeah. And he's drowsy, sorry. And he has this reduced urine output as well. And you want to check for the source. So I kind of gave it away here by saying that he's got this kind of tenderness and erythema around his PICC line. So that's probably the source of the infection. We'd also do a chest X-ray, may consider CT, but do a urine analysis and check the extremities as well for any source of infection. Okay, I'm just going to go back to the previous question because I had someone asking. So they just wanted me to explain the free fluid and gas in the scan. So this is just one of those CT findings that you find with kind of inflammation around the kidneys. So it'll just look like linear streaks of gas and fluid collecting around the kidneys because of that kind of infection and inflammation due to the pyelonephritis. I can't really explain why, but it's one of those typical hallmarks of pyelonephritis on a CT. Hope that answers your question. Okay. Okay, 2 more questions. I'm almost at the end. So you got a 76-year-old man who sees a GP, complains of generalized tiredness and fatigue and feels short of breath easily when he's getting around. He's fully independent, mobilizes with a stick. You decide to do some blood tests on him and you suspect iron deficiency anemia. Which of these cell types would you not find in a blood film for this patient? I'll give you about 30 seconds. Okay, so the answer is D. So all the other ones you will see in iron deficiency anemia. So if I just point out a few in here, so you got this, which is one of your pencil cells. Not a very good one in here though, but on the next slide there's better pictures of it. You can see most of these cells are quite hyperchromic. You got some smaller ones here and here, so that's your microcytic ones, and your target cells. Not very good examples here, but you can maybe convince yourself this could be a target cell. Okay, this is a really useful picture, just kind of pointing out the different ones. So here's your pencil cell here, which looks a little bit more convincing, and target cells, it looks like an actual target here. So you can see a little bit of darkness in the middle. You can see the ring around the outside as well. And some of the other ones that you can get is like teardrop red blood cells, which look more like like a little hair drop or teardrop. So, okay. So this one, echinocytes, I can never say it properly, is something you find in kind of liver disease or someone who's had their spleen removed. And then these are some of the other things that you might see as well, which you can kind of look through in your own time. Okay, last question. Well done for sticking it out. So we've got a patient who comes in complaining of being tired all the time and bruising easily. On blood tests, you note that they have pancytopenia. On a peripheral blood film, you see significant abnormalities. What is the most likely hematological malignancy here? So I'll give you about 30 seconds. And if anyone could tell me what the abnormality is in the blood film, that'd be great. Oh, so the answer is C, and yes, it is our rods. So I put this picture together, slide together, just looking at the different types of leukemias and what kind of pathology you'd find. So that's your AML here. So you can see these little rods, kind of crystalloid rods in there, which are oil rods. ALL, you'll just see these large lymphoblasts. In CLL, it's these smudge cells in here that you can see. And then for CML, you'll see all these immature granulocytes. Oh, and that is the end of my session. So if anyone's got any questions, please do put it in the chat. And please do fill in the feedback form, which I'm going to post in the chat as well. But thank you guys, and thank you for everyone else who presented today as well. And if you have any issues or any kind of questions, I'll put my email at the bottom of the slide here, and you will have access to the SBA bank at the end of the feedback form as well, which has a total of 115 questions in it.